We are here with another episode of the Erectile Dysfunction Radio podcast, where we tackle the facts, explore the myths, and provide real solutions to help you take control of your sexual health and confidence. I am Mark Goldberg, certified sex therapist and host. For any men who are serious about resolving ED or other sexual challenges, we encourage you to visit our website, erectioniq.com, and use our additional resources. Reach out to us with questions or schedule a 15-minute consult with myself or one of the members of my team. We are passionate about helping men like you, so do not hesitate to reach out. Today we are joined by Dr. Jenn Bossio. Dr. Bossio is a clinical and health psychologist with a private practice in Ontario, Canada. She has published extensively on men's sexual health issues and joins us today to discuss cognitive behavioral therapy as a treatment for psychogenic erectile dysfunction. Dr. Bossio, thank you for being with us.
My pleasure.
Okay, so to get us started, can you share with our listeners how you conceptualize psychogenic erectile dysfunction, and how do you differentiate between psychogenic and physical erectile dysfunction?
I think it's a good question, and I will tell you that although I am primarily a healthcare provider as a mental health care provider as a psychologist, in the work I do, I actually really don't differentiate between the sort of etiology or the causes. So when I'm looking at how to conceptualize erectile dysfunction, I'm using something called the circular sexual response cycle, which was designed by a sexual medicine physician by the name of Rosemary Basson. And so this is a model that's quite comprehensive. It really is like a biopsychosocial approach to looking at all of the factors that contribute, either hit the gas pedal or hit the brake pedal of sexual arousal. So that is the model. I'm happy to go into more detail, but that's the model that I look at. I'm not so interested in where it comes from.
Okay, so that's really interesting. So this is also referred to as like a responsive desire model. Is that the similar?
You got it. Yeah.
Okay, perfect. So can you speak a little bit more to not focusing on the origins or the
Totally.
etiology of the dysfunction?
Totally. And I'll tell you why and where this comes from. So when I was doing my postdoctoral fellowship, so I was at UBC out in British Columbia, Canada, and we were looking at applying mindfulness-based sex therapies to a male population. And the reason for that is pretty much as soon as Viagra came out in 1998, everyone put up their hands and say, yay, we've cured male sexual dysfunction, put them to the side, and now it's time to focus on women's sexual health. And that's great for women's sexual health because there's a lot of questions and answers needed. But what it means is that men were really slotted into this sense of erectile dysfunction is physical, you take a pill, it's fixed, and that's it. And so while we were doing this research looking at mindfulness for erectile dysfunction, we were looking at a bunch of different populations. Some, the kind of psychogenic, and again, I don't even love that term, but I will use it, the psychogenic ED, but we were also looking at men dealing with prostate cancer. And so the vast majority of treatments for prostate cancer result in some form of sexual dysfunction, erectile dysfunction specifically. And so we were using these interventions for men either where it's, again, like quote, ED's happening in your head or very much in your body because the nerves have been severed or the area has been radiated and physical damage has happened, and we're not really expecting erections to recover much, certainly not to pre-prostate cancer treatment levels. But our focus was actually moving away from erectile functioning as a performance and moving more towards sex being an enjoyable experience, regardless of what the penis was doing.
Interesting. So it's much more of a pleasure and enjoyment based approach than it was about restoring function. Okay, which is what would take you away from a psychogenic as opposed to physiological, origin.
Yes. Yeah. And so I can speak a little bit more about the irony of doing that, of focusing less on this outcome of a rock solid erection, and that is it, and moving more towards pleasurable sex. What it actually did, especially for our non-prostate cancer population, is it freed up a lot of mental space for people
Mhm.
to focus on all of the fun, sexy bits that hit the gas pedal of sexual arousal. And lo and behold, we started to see some improvements in erectile functioning. And even with the prostate cancer men, the folks where we weren't expecting any change in sexual functioning, what we were seeing was improvements in their sexual lives, not only their sexual lives, but the sexual lives of their partners, so people sleeping with them. And so sex was getting better. And for folks for whom erections could improve, we had evidence to see that it was improving as well.
Yeah.
So taking this like sideways approach.
Yeah. So I mean, I like what you're sharing about that, especially because it's um, a lot easier to follow in a lot of ways, and it's a lot less
Sure.
confusing, right? Just getting pleasure focused. And again, the premise is a strong premise, because that oftentimes is one of the missing elements, both in terms of what is necessary to fuel just the natural, arousal, leading to erection process. And if you are focused on pleasure, it's highly likely that you are a lot less focused on performance and anxiety and some of the other breaks, if you will, that
You
get in the
got it.
way of
Mm-hmm.
erections. Okay, that is great. So, in your experience, and I understand the model here is much more focused on getting. It was much more about getting people focused on pleasure. But in your experience in working with men who are experiencing ED, what are some of the most common psychological triggers that you find?
Oh, yes. We tend to see this sort of feedback loop that happens, particularly between the brain and the body. Go figure, these two things are very important in sexual arousal. So, the way I explain it to my clients in clinical practice, I'll explain it here. And I'll go back to the days when I was doing my PhD. I was actually looking at sexual correlates of circumcision. That's a whole other story. We will not get into it today. Um, but essentially, what was happening is we were testing penile sensitivity in a lab setting. In order to be able to get good measures of penile sensitivity, we had to ensure that men were not sexually aroused because, believe it or not, more sexual arousal leads to less sensitivity in the penis, which at first I was surprised by, but then I thought, the penis is kind of like a battering ram. You don't want it overly sensitive during sex. So, however, in the lab setting, every so often, arousal would happen. And that's fine. We would address that very simply by saying, okay, please count backwards now from 700 in multiples of 7 out loud. Go ahead. And do you want to guess how long those erections lasted for?
I don't think they got to 600.
Not even close. It was truly within about 1 to 2 seconds, erections were completely gone because there were two things happening. The first is that I don't know about you, but it takes like every neuron in my brain to count backwards in multiples of 7. I don't know what comes next. So it is very cognitively taxing. I am no longer thinking about all of the sexy things that might have led to arousal. I'm just thinking about the next number. So the cognitive distraction was big. The second thing is these poor gentlemen, I thank them greatly for coming out for science, but they're sitting in a really awkward situation. They're being told to count backwards out loud. It makes my palms sweat just thinking about it. It's very stressful. So the combination of stress as well as cognitive distraction completely destroyed a sexual response. And that's really what we see. So it's this feedback loop that happens between the brain and body. Often what we tend to see is like erections naturally wax and wane. For a man, maybe the last couple times their erections weren't what they wanted them to be. They're going to come into a sexual encounter with a partner or not, and they're going to be hyper focused on like, oh God, when am I going to lose my erection? And then the erection naturally starts to wane a little bit. And then their brain goes, oh, great, here it is. It's happening. And then what happens in the body? The heart rate starts to kick up. The stress response kicks up. And then they say, oh my God, my partner's going to notice. They're going to feel like I'm not attracted to them. This is the worst. It's going to be terrible. And then before you know it, erection is completely gone and good luck getting it back. So there's that
And
vicious
yeah,
feedback
and
loop.
what I'm hearing from you is that those cognitions hit on both cognitive distraction and stress.
Perfect. Yes,
Okay.
exactly.
Okay, and all that kind of hits this feedback loop because it sets off the body, and then that sets like this, negative feedback loop between the body and the brain.
Yes. Mm-hmm.
Okay. Now I know that you mentioned earlier that you don't draw a particular distinction between, like, if it's physiological or psychological, kind of look at the patient as a whole,
Yeah.
looking to help them just improve their overall experience. In the work that you do, to the best of your ability, because I imagine that you're a pretty astute clinician, how prevalent is a psychologically based sexual dysfunction compared to a physically based erectile
Hmm.
dysfunction?
Well, certainly, I do get a bias sample because I am a clinical psychologist, not a urologist, but we do get a great deal of referrals from urology. And so, what we see, the vast, vast majority, it is what I think one of the biggest contributing factors is psychological. And so, all of that to say is these are men who have really healthy penises. Nothing is wrong physically. We know kind of the big leaders behind those physiological explanations for erectile dysfunction, the prostate cancer, as I've already mentioned. Cardiovascular issues are another really big one. Diabetes is another big one. Those are kind of the big three that I consider. Most people have none of that when they're coming in.
Mm-hmm. I think it's been a very similar experience for me as well. The vast
Yeah.
majority of people do not have those conditions, and if they do, um, most, if not always, those conditions predate
Hmm.
any erection challenges and whatnot. They don't seem to be primary contributing factors. But again, it's a sample. It's a biased sample, because like those are the people that we tend to see. Now,
Hmm.
I'm really excited to get into CBT, because one of the areas that our listeners are asking us for more information about is how do they actually work on this? How does treatment actually work? We talk a lot about contributing factors. We are a little bit less explanatory when it comes to treatment. So to get us
Hmm.
started, can you give us a brief overview of what CBT is and how does it seek to positively impact change in people?
Sure. And I'll give you a little bit of both. We think not to go too deep into it, but when we're talking about these like waves of psychological evidence-based treatment, CBT, we consider the second wave following like the psychodynamic first wave. And then mindfulness-based therapies, we consider the third wave. So it takes CBT and it kind of goes a little bit further. So I will say most of the research I have done when it comes to men's sexual health has been mindfulness-based, but it links back to the CBT. And we have done some CBT research. All of that to say, there's very little research in terms of men's sexual, like sex therapy for men's sexual dysfunction. The majority of it is in mindfulness, but there's a little bit in CBT too. So to answer your question, CBT, when we have good evidence to suggest it works, it really is looking at the combination of the thoughts that are going on in our head and the behaviors that we are doing. We don't really have control over the stuff that our brain tells us, but we do have control over the stuff that we do. And we know that thoughts tend to follow behaviors. So when we act a certain way, our thoughts kind of start following those. So there are a number of different cognitive behavioral tools. One of the best ones, especially when we're talking about erectile dysfunction, is learning to identify these really unhelpful thoughts that come up and hit our brake pedal with sexual arousal, but then to challenge them, to fight them, to be a little bit of a judge, if you will, judge, jury, executioner with our thoughts and teach ourselves that those thoughts are not actually fact. Mindfulness is really similar and yet exactly the opposite at the same time, in that, again, it is identifying our thoughts, but it is essentially unhooking from them. It's noticing them, it's letting them pass as if they are leaves floating along on a stream. And again, not acting as if they are fact, but it is just a thing that my friggin' brain is doing. And I am going to once again engage, let's say, sexually with my partner in a way that matters anyway.
Okay, so if I'm getting quick, the C in the CBT is the
Mhm.
cognition side of it, and the idea is
Mhm.
that
The
we
thoughts.
have all kinds of thoughts that get activated inside of our minds.
Mhm.
Many of them are not fully true, at least, or some of them are totally not true. And the more we feed into those thoughts, the more anxious we become, the more performance focused we become. And
Mm-hmm.
what I'm gathering is that there's, like, again, the two approaches that you're laying out. One of them is to identify and to challenge these thoughts, and the other one sounds almost like metacognitive, where you're just going to recognize that the thoughts don't carry a lot of meaning, so you're not going to infuse them with a lot of meaning, just kind of let them float away.
You got it.
Okay.
Exactly.
Now, on the B in the CBT, on the behavioral side, can you speak just a little bit
Mm-hmm.
to what behavioral therapy means?
Yeah, so behavioral therapy really teaches us to act in a more adaptive way. So, to give a solid example, when we're talking about erectile dysfunction, let's say you're engaging in sex with a partner. Your erection isn't going the way you want it to go. If I were sitting there watching you with a video camera, which I swear is not part of the sex therapy I do, that's a totally different thing. But if I were watching you on a camera, the stuff that I'd see is the behavior. So if suddenly your face falls and you turn in bed away from your partner, or you get up without saying a word and go to the bathroom, and you sit there and you are just kind of, drowning in shame. Those are all behaviors that CBT affects to change. So perhaps the idea would be in that moment, instead of completely shutting down when erections aren't working reliably, we engage in a different sexual activity. We provide oral sex for our partner, and then we focus in on that oral sex. And then maybe, just maybe, we experience all of the pleasurable, fun gas pedals that come along with that, and an erection returns. So that's a bit more of what the B part of the CBT looks like.
Okay, that is helpful. So, Dr. Bossio, can you speak to whether CBT addresses symptoms or the root causes when it comes to erectile dysfunction?
My the way that I view it is that it addresses the root causes. So root causes being, for example, again with that C and that B, the thoughts that come up around sex. Men in particular, I would say everyone, but men in particular are bombarded with these really, really unhelpful myths, societal beliefs about what a real man should be. And I'm using air quotes here. So a real man should be ready to go at any time. An erection should be completely reliable. A man should be entirely responsible for his partner's pleasure. A man should be orgasming, lasting as long as he wants. All of these different beliefs. And so that can really lead to a lot of, understandably, challenges. And I got so excited about my myths here that I've lost track of the question. What was the question again?
So the question is, does CBT, like, is it just basically
Oh,
a band-aid or a patch?
underlying.
Are we just addressing the symptoms, or does
Right.
it actually get to the root causes and
Right. Thank you.
facilitate more of a like significant lasting change?
Lasting change, yes. Well, you can imagine that if you are living a sexual life with all of these myths going on, there is no way that you are going to be totally calm, totally relaxed, and totally present, the necessary ingredients for good sex to happen. So if CBT allows us to unhook from those thoughts, challenge those thoughts, or find evidence that those thoughts aren't necessarily true, then suddenly we are going to come into a sexual encounter with a much more regulated nervous system, much more calmer, that parasympathetic nervous system, as opposed to the sympathetic, highly stressed, which is incompatible with a sexual response. Same thing with the behaviors, right? If we have more of these healthy behaviors, perhaps less of a performance-based approach to sex and more of a pleasure-based approach to sex. Again, those are things that if we were watching on a camera, we would see, not part of sex therapy. Those again would really address this underlying cause that leads to this erectile breakdown, basically.
Okay, so can we just get a little bit further into, like,
Yeah.
your perspective or conceptualization about how these thought patterns influence, like,
Hmm.
the sexual performance? And I'll say that with a lowercase p, but in other words, like, what is the link, to the extent that we can understand this, between
Hmm.
a person's thought patterns
Hmm.
and how that gets all the way down into determining whether erection is going to occur or not?
Yeah, totally. The very short answer is it has to do with the nervous system. So, in order for a sexual response to be possible, like a physiological sexual response to be possible, a person needs to be in a calm parasympathetic state. So, if you think back to our evolutionary ancestors, the ones who developed this fight or flight response are the ones who survived, right? If they see a saber-toothed tiger out on the savannah, I know those things don't match up. But if that is what happened, the ones who would either punch the saber-toothed tiger in the face or run away, fight or flight, they are the ones who would survive, and they pass those genes on. And so you can also imagine that if a saber-toothed tiger creeped up while our little caveman friend is in his cave having sex with a partner, and he saw the saber-toothed tiger and he's like, I'm just going to continue on here and I'm just going to keep having all of the sex that I want, that guy's going to get eaten and killed. And so having that fight or flight response kick up and in turn shut down a sexual response, be it desire, be it arousal, be it ejaculation, and this is kind of gets into early ejaculation and why that happens. It's also a stress response. But when we have that stress response, sexual arousal immediately decreases. So what else causes a big stress response? All of these very stressful and distressing thoughts in our head. So when we go into a sexual encounter, predicting that it's not going to go well, that is stressful. Imagining all of the times that it didn't go well, that is also very stressful. And so there is really this direct link between the thoughts in our head and the emotions that we have, i.e. anxiety, and our parasympathetic nervous system kicks up, and then a sexual response is impossible.
Okay, that is really, really important for our listeners to understand just that link. It's obviously very, very intricate in terms of like how the nervous system actually sends those signals and whatnot. But big picture, what we do know is that what you think is oftentimes what you end up getting. So if you think it's not going to go well, that's oftentimes what the outcome is. If you are pleasure focused, then a lot of times that's what the outcome is going to be.
And I'll even specify a little bit there. Like you can have the thought it's not going to go well, but if you believe the thought it's not going to go well, then you're going to have a bad time. If you have that thought it's not going to go well, and you tell your brain, oh, here's my little like monster on my shoulder who's saying this crap again. Okay, whatever. It's fine. I'm going to go and enjoy my time anyway. That thought is not going to have a big impact on you.
Okay, that's an important distinction. So it sounds like we're getting back a little bit more towards that mindfulness piece.
You got it. Yeah.
Right? And not infusing that thought with too much meaning.
Exactly.
Okay. Now, do you see mindfulness as a part of CBT? Is that the way you conceptualize it? Do you see it as a separate approach?
I see it as, like I said, similar but different. Mindfulness is very distinct from CBT. So the big similarity is that both of them involve being aware of your thoughts, behaviors, emotions, physical sensations, but that's where the similarity ends. Mindfulness is absolutely not about challenging the thoughts, getting rid of the thoughts. It really is, I'm noticing those thoughts are coming up, and I am going to be aware of them. I am going to notice all of the impact to my brain, my body that's happening as a result of those thoughts. And that essentially inoculates us against those thoughts being so powerful. So it's the difference between saying, uh-oh, I'm losing my erection, it's never coming back, from saying, oh, I'm losing my erection and I notice my brain is telling me that it's not going to come back. Okay, brain, you sweet dummy. You go, you say what you're going to want to say. Of course, you're going to tell me fearful things because sex is so important and you want me to have a good sexual experience. I'm going to put you aside and I'm going to focus on what matters anyway. There is a great deal of research that supports mindfulness now. As I was mentioning, it is this third wave of therapy. And so the amount of research is indisputable at this point, that mindfulness is a very effective strategy at reducing stress, also at reducing depression or improving mood. And so for those same reasons, we have really good reason to believe that mindfulness is effective for sexual functioning.
Okay, so I want to move on to what's become a bit of a buzzword, but I do think it's a real major element when it comes to sexual function is performance anxiety. So can you speak to just what your take is on performance anxiety, and what are some of the common performance-based cognitions that men hold onto or loop around with?
Yeah. I always joke that the penis hates being on the spotlight. As soon as he's on the spotlight, he shrivels and goes to sleep, right? He does not like it. And so a lot of the performance-based cognitions that people come into the clinic with, I might have already mentioned this sense that I should have a rock solid erection at any time. as if I love my partner, if I'm attracted to my partner, if I'm a real man, my penis should perform on demand for as long as I want. And I should also always end with a giant mind-blowing erection. And so those are like some of these ideas. Again, I'm responsible for my partner's pleasure, and a penis, i.e. a erect penis, is necessary for my partner's pleasure as well, which if we get a whole slew of heterosexual women in here, they would actually argue with that. And also research does support that an erection is one of the least important things for women's sexual pleasure. But of course, when we are fed this by porn, by movies, by books, by our buddies, these things feel so real. And so it isn't this sense of like, let's go in and just have a fun time, because sex really is meant to be adult play. Instead, we come in as like, okay, now it's time to perform. Now it's time to prove myself as a man. And that's exactly when the penis loses it. He hates that.
Okay. Now, from a CBT perspective, what would be an example of an intervention or a tool to
Mhm.
counteract some of these thoughts?
Perfect. I'll give you two. I'll give you a cognitive and a behavioral, but they both kind of tie together. Cognitive would be we identify the exact thought and we challenge it. And we don't challenge it with our feelings, or we don't challenge it with whatever Reddit says. We challenge it with facts. So if three different people were to observe this statement, they would all agree with no background knowledge that yes, this is a fact. So an example, simple example, would be if I have the thought that my partner cannot enjoy themselves unless I have a full erection for 25 minutes, I can ask my partner. And I could say, hey, hun, this is the thought that I'm coming with. Tell me, what is your opinion? And partner might say, well, actually, after 25 minutes, I am so raw. I am like begging for this to end. In fact, what I really like is when you go down on me. And then, penetration is nice, but I don't need it. Right. So now we have disconfirming evidence. That evidence doesn't make the thought go away instantly and forever. But what it does is now every time that thought comes up, we notice it and we say, well, actually, my partner said otherwise. Okay. And of course, then we could say, well, my partner's just lying and trying to make me feel better. But this is kind of the evidence that we have. And we might take a tally, we might take a poll. But again, it's looking for this kind of factual based stuff.
Okay. Before we jump to the behavioral one, just for a moment, I want
Yeah.
to ask a question off of that. So, with that type of intervention, is that something that you would tell a client or a patient of yours to implement in the moment when the thought comes up? Or is this more of an exercise that a person should be working on, like prior to or post sexual activity? Because I could imagine that it also is very distracting identifying the thought and then trying to challenge it in the moment when you're like trying to get into be pleasure focused and
Mhm.
very much there with your partner. So how do you prescribe this type
Well,
of
such a
intervention?
good, yeah, that's a really good question. We don't learn how to drive on the highway. We learn on the parking lots. So exactly to your point, we're not doing this in the moment. We are doing it after the fact or before the fact. I'm aiming to usually do these interventions when we're feeling quite calm and safe in our bodies. And during sex, especially if ED is maybe on the table, that usually isn't the time to do it at all. So really good point.
Okay. Now
Yeah,
the behavioral intervention, sorry.
behavioral intervention. So another thought that might come up is this idea of, men often experience a sense of almost disgust or disappointment or shame when their penis is flaccid during a sexual encounter. And so one tool that we do in order to inoculate ourselves against this, because again, that vicious cycle starts going, right? Uh-oh, I'm flaccid. I shouldn't be flaccid. This is horrible, etc. So one thing that we do is we actually aim to either gain and then lose an erection. So this can do two different things. One is it addresses that really strong emotional response that comes up to a flaccid penis in a sexual encounter. And usually we start this alone. We don't bring a partner in for a little while. So it would be during masturbation.
Mhm.
Another example is this thought comes up, well, once I lose my erection, it's gone. That's it, right? I'm done. We're out of here. And so again, we gain an erection and we lose an erection, we wait, and then we bring the erection back. So going back to that sexual response cycle, we're thinking of all of the different things that lead to hitting the gas pedal that lead to an erection. So after we lose it, we're thinking of all the different stimuli that we can use: touch, sight, stimuli, fantasy, all of these sorts of things, making sure that the context is good. Doing some deep breathing to calm our body, make sure we're in that parasympathetic calm state. And then we bring the erection back. And now that starts to be a behavior. So we're practicing gaining and losing it. But also B, it's fighting that thought. Once I lose my erection, it'll never come back. Because in fact, unless we experience ejaculation, then we have this refractory period that could be anywhere from seconds to days for some people between one erection to the next, or between one orgasm to the next. Erections can come back after we lose it.
Yeah, that's like a really, really helpful example. What I love about that intervention is that it really hits on both aspects, both the behavioral, but also
Totally.
that action does become the evidence, right, that could be used in challenging some of those unhelpful thoughts.
Yes. So as we get
Okay,
practice doing that alone, then you might actually bring a partner in to do it as well.
and transfer it over. Okay,
Hmm.
so to wrap us up, I'm wondering what your take is on the use of PDE5 inhibitors for a person who does not have any identifiable physiological issues.
Hmm.
How do you look at that? And if a patient or client were to ask you, should I do this? Should I not do that? What is your approach?
Yes. So I always go to the research that shows that men who are prescribed PDE5 inhibitors typically stop using it after about 6 months, irrespective of treatment effectiveness. So what that means is they might take Viagra and they get erections really reliably, but after 6 months, they stop using it. And it's for a lot of really good reasons. It's expensive. It kind of kills spontaneity, these sorts of things. Although I will say, I am actually against spontaneous sex as a sex therapist because it just puts us on the spot too much. But anyway, um, and so for all these reasons, they stop using it, but also because it really isn't addressing any of those underlying thoughts, beliefs, feelings that we've talked about. So I tend to take a individualistic approach. It depends. I am not anti PDE5 inhibitors, but I know that it isn't a long-term solution. So if we have a person who is super anxious, who just needs some evidence to show that they can get an erection or get an erection back, something like Viagra, Levitra, Cialis might actually be helpful for a little while. Just starting to build up some of that confidence while we're also doing a ton of work to move away from performance. But as a sex therapist, I don't want to send my clients into a situation where they're going to fail miserably and just make things worse and reinforce all of the catastrophizing thoughts that they have. So if it's a helpful tool, great. And generally, I will say, even without my own recommendation, most of the men that I work with are aiming to reduce their use of it anyway. Some people keep using it and it's just that like kind of safe ace in the hole kind of thing, like it's in their back pocket, and that's fine if that works for them. But generally, when we're moving more towards that pleasure-based sexual model, it's not necessary, and men don't feel it's necessary.
Yeah, it's a great answer. And just hearing the way you handle that question, a lot of the other questions, very affirming for the work that we do over here, because I
Hmm.
think we do see a lot of the similar things to what you are describing, the cognitions that men have, also just this like approach to PDE5 inhibitors, like that, and both approach to
Yeah.
help people get out of those loops. I just think it's really, really great. This has been fantastic. I really, really appreciate having you here on the podcast. For any of our listeners in Canada who are looking for a clearly well qualified sex therapist, to help them with these, we want to make sure that we leave Dr. Bossio's link to her practice website. So don't hesitate to reach out to her. She could be of help to you. And once again, thank you very much for being here.
My pleasure.